And then the other one was
This is Dr. Kristin Thomas and Dr. Joshua Yamamoto uh, doing timely topics, and we are real doctors.
doing real medicine.
So there are a couple of stories in the news today that, or this week, worth commenting on. First of all, I have to say I have a band-aid on my left arm, and that would be
And so do I, Dr. Yamamoto.
because I got a flu shot today. It's early November in the Washington area. This is the ideal time to get flu shots because our flu season does tend to be more around what, January, February?
Usually peak flu season is going to start in January, but of course, COVID messed everything up the past 5 years. So instead, we've had a number of curves that you used to be able to see on the MMWR emails that came from CDC that would give us a distribution of times when people would get influenza,
What is
but we don't get that anymore.
MMWR?
So that is the report that comes out of the CDC that gives us an update on a regular basis of current trends in infectious diseases, including influenza. And that kind of nicely leads into the next topic, which is a paper that I just read hot off the presses, which was really quite good. I will put the link on our podcast today because it's an excellent review of influenza. And in particular, how, sadly, this year's influenza shot missed a mutated strain of H3N2 called subclade K. Now, unfortunately, this mutation happened around the same time that the flu shot was being designed in June. So, our flu shot that you and I just got today is not likely to protect us from this new subclade. And we do know it's circulating in Canada and in the United Kingdom, but we don't know where it's circulating in the United States because, again, the CDC report on what's circulating is not
So,
available.
is there going to be any other way for doctors to get information about these spreading infections? What else can we do if our traditional sources of information may be a little dried up?
Well, already the University of Minnesota has decided to combine forces with NEJM, New England Journal of Medicine, to make a substitute for the MMWR report. So that should be eventually coming, and I'm already signed up myself for a bunch of emails that should be coming from CIDRAP. That's capital letter CIDRAP. And I guess you probably could sign up as a layperson, as a patient, because it's a nice, quick summary of what's happening in infectious diseases in the United States right now. It talks about the measles outbreak. There's a going strong measles outbreak in South Carolina right now. They're also talking about the whooping cough outbreak in Louisiana,
I did hear
which is
piece
coming from decreased rates of tetanus booster
good news about
immunization.
measles that the vaccination rates in Texas suddenly shot up, which
That
is
was a
good
great
thing.
news report this week. I heard that as well this morning, Dr. Yamamoto.
So you've mentioned to me before that guys about my age, and I won't tell you how old that is, but we needed to consider whether or not we still had measles immunity. What was that all about?
Correct. So, what I'm trying to do with my annual physicals is look for patients born between 1958 and 1968. And we won't tell anyone if you met that category, Dr. Yamamoto,
But
but I will
measles,
proudly say I did not. So, as the youngest person in the classroom in medical school, I was not born from 1958 to 68. So, I was pretty secure in my measles immunity and I did not check my antibody levels. But Dr. Yamamoto, I did recommend that you check your antibody levels.
which I did, and I had adequate measles immunity. Measles is something that is astonishingly contagious, and it's kind of important that we all maintain our immunity. I wanted to circle back just a second to influenza. You know, it's enormously important. I had the kind of privilege to take care of one of the only people in the world who both got sick with the original influenza outbreak in what was it, 1917, and COVID in 2020. Yes, she was 107 years old. They wrote a story about her in the Washington Post. The thing is she got through both of those infections, and she got through the COVID infection largely because she had maintained her health so well. During the pandemic, we used to say one of the best things you can do to anticipate surviving any viral infection is to be healthy. So, seeing your doctor, maintaining your health, And realize influenza is still an awful disease. It kills usually what, 10 to 20,000 people
More, definitely
more
more per season.
every year, and it's been doing that for over 100 years. So absolutely get your influenza vaccine.
And now is a great time to do it. I think many people know, if you're my patient, that I recommend that you get your flu shot towards the end of October to mid November. So, Dr. Yamamoto and I indeed got our flu shots today, which many might say is too late. But frankly, again, the flu shot really is most effective in the first 90 days after you get it. It takes 2 weeks to develop immunity. And thereafter, in those 90 days, you actually may not get influenza if you come into contact with someone who is contagious because your flu shot actually prevents infection. Thereafter, you will have a less severe case of influenza. So after those 90 days, you're not fully protected against transmission. But if you do get influenza, your symptoms should be less. But really, that 90-day period, especially for a doctor seeing patients face to face, as I do every day, is critical for me because I don't want to get influenza. I got it once in 1997 when Dr. Yamamoto and I were working at Hopkins. And that is something I never want to repeat
For the
because
record, I
those
wasn't the one who gave it.
those cardinal symptoms are severe headache. You'll read this in the article. A fever, usually of 101, total body aches. So during endemic flu season, when we go December, January, February, if you have those symptoms of headache, total body aches, and a fever of 101 degrees, yes, you could have COVID, but honestly, more likely it's influenza. And what I did on the way home, at the stoplight, not while I was driving, was quickly Googled to see whether or not you can get a combined COVID and influenza test for home use. They are available. The one that was authorized from Pfizer was called Lucira. That's Lucira. And there's almost no reason for me to tell you that now because it was under emergency authorization use. So it is no longer available. Nonetheless, there are many other ones available. You can Google that and find the many other combination influenza COVID tests. So if you want to have one at home because flu season is clearly around the corner, you can do a self test. Binax now, a lot of us remember, Binax is one of the brands that is available for purchase as a combination influenza test, COVID test. And I think those are nice to have at home.
Now, as I understand it, there's a reason, particularly for influenza, to get diagnosed early, right? Isn't there something you can do about influenza if you get it?
Yes, Dr. Yamamoto, you can. So,
Not too bad
um,
for cardiology.
if you are an at-risk person, if you are elderly, if you have what we call comorbid, that's comorbid, comorbid, it's kind of a bad word, but we use it a lot in medicine. It means you basically have other medical problems. So that's doctor speak for I have other medical problems, diabetes, heart disease, asthma. If you have these comorbid medical problems, it's probably a good idea for you to, in conjunction with your doctor, decide if you should take Tamiflu or, better yet, if you can afford it, Zofluza, Xofluza. Zofluza is a one-dose pill that amazingly eradicates influenza very quickly. Tamiflu you usually would take for 5 days, twice a day, but Zofluza can be one dose. It's just incredibly expensive. You can use a coupon only if you're not a Medicare patient, and you can use that in conjunction with your insurance to try and get a discounted Zofluza prescription. It was so popular in the past couple of years that pharmacies ran out of Zofluza. So you can talk about that with your doctor. It definitely helps treat symptoms.
So, will these medications help for particularly viral infections that are not
It will
influenza?
absolutely not help for other viral infections, Dr. Yamamoto. So
So,
I
if I get a
do
cold,
recommend, no, please
if I have a
don't.
head cold and I'm
Exactly.
coughing,
No,
sniffling, sneezing,
no.
stuffy head, fever,
Don't
and I
do
need to
that,
rest,
Dr.
just
Yamamoto. That's not
take
a good
my
idea because you're taking Zofluza away from people who need it. You're taking Tamiflu away from people who need it. And it's not a nice thing to do.
maybe it's worth a moment to point out that viruses, right? They generally do not have specific treatments, with the exception of influenza.
That is correct.
Um, I want to ask you.
especially viral upper respiratory infections. And that is the season we are now entering. And just a side note, I want to mention that because we don't have a lot of available disease tracking and reporting in the United States like we usually do, we do know that there has been a significant uptick in the United Kingdom in RSV infections in children in the past month, respiratory syncytial virus. It hits the children first. So we are anticipating that we will have an uptick in respiratory syncytial virus in adults this month, November. So, just a pitch, if you did not get your RSV vaccine, which came out in November of 2023, get it now. It lasts about 18 months and it is very good protection. If you had Guillain-Barré from the flu shot, don't get the RSV vaccine. But otherwise, it's an excellent vaccine, and we definitely want to reduce the rates of RSV infection.
If you don't know what Guillain-Barré is, I guarantee you didn't have it. It's an incredibly rare reaction to these vaccines. With
You would know if
you
you
would
had
know,
it.
it's not
Exactly.
a subtle thing. Now, if I remember, now I take care of adults mostly. When I went to med school, RSV was just a little kid virus. So now it's really getting into the adult population. Is that what we're saying?
It can be lethal to elderly people. So that would be in particular
But not me.
people over 75. No, you're not elderly, although you could be at risk for measles if you don't check your
I
immunity.
check my immunity. So I like to tell my patients, because as a cardiologist, most of my patients are elderly and by definition have comorbid conditions, that particularly if they're around grandkids or school age kids, that it really is worth it for them to be vaccinated. Now, is there a sense of how often they should get an RSV vaccine? You mentioned immunity is good for a year and a half or so.
Right. It looks like it lasted 18 to 24 months, but the government is not studying if we should do a booster shot, to my knowledge. And right now, only pharmacists can give out the RSV vaccine. It's tied to reimbursement through Medicare D, and they won't do a booster. Now, if you're immunocompromised from chemotherapy or cancer, maybe you could get a pharmacist to give you a booster shot, but right now it's not something being actively studied.
So while we're still on viruses, a couple of things that I wanted to ask about. Um, Obviously, the a topic of great concern to many of our patients is COVID boosters. What guidance have we all been given, and how do we personalize that about COVID boosters?
Well, right now, the recommendations have been very confusing, and that a lot of that had to do with the
So
ACIP
what do
meeting.
real doctors tell?
So, real doctors tell real patients, at least this real doctor, that if you think you're at risk for severe COVID illness, it would be a good idea to get a COVID booster. But if you don't think you're at risk for severe COVID illness and you don't want to get a COVID booster, talk about it with your doctor for the pros and cons. But it really should be that doctor patient decision, shared decision making that gets you to take your COVID booster or
So, as
not.
I understand it, the
It's not
influenza shot
mandated.
is really good at preventing infection. But is that, can we say the same thing about the COVID vaccine?
No, unfortunately, the COVID vaccine does not look like it actually prevents infection.
So what's the point?
It lowers severity of illness.
Ah, so but aren't we getting good news about the severity of COVID?
We are getting great news about the severity of COVID as long as you're not an elderly patient or immunocompromised or have an immunocompromising disease. Yes, it's mutating more to be like the common coronaviruses. But right now,
And a common
in
coronavirus is really a bad cold.
it's a bad cold.
I
But
mean,
right now,
it's
in
cold, but
respiratory virus season, it's going to be confusing, and that's why we wanted to do this podcast today to help people clear some of the muddy waters about what vaccine should I get, how can I test for it, are there therapeutics available, and what's on the horizon.
all right. Now, just
I do have a different question though,
sure.
Dr. Yamamoto, if we can pivot off of viruses.
Oh, I just love viruses.
I had a patient ask me today if they should still be taking their melatonin because they saw a study this week that said that they're afraid their melatonin is going to give them heart failure. What do
So
you think about that as a
now
cardiologist, Dr. Yamamoto?
that, oh gosh, more than it's worth. That made the press because very recently the American Heart Association national scientific meetings were held, and there was a paper presented showing a possible association between melatonin use and heart failure. Now, oh my gosh, let's run with that. The press can have a field day, which in some
So,
places they did.
do some places call this clickbait, Dr. Yamamoto? Is
Yes,
this considered
this
medical
is this is
clickbait?
this is incredible clickbait. And I was going to play a sound effect on what we should do with clickbait, but I'll avoid that. All right, so there's a lot of things wrong with it. First of all, quite simply, correlation does not imply causality. Just because something is related doesn't mean it was causal. Next, there's all sorts of issues. I'd take a, if you don't mind, a moment to talk about melatonin. You can buy melatonin to help you sleep, but what exactly is it? Melatonin is actually a hormone. It's a hormone produced by the pineal gland. And who on earth has ever heard of pineal glands except for people who watched really bad B movies in the 1980s? Anyway, the pineal gland is at the base of the brain, and sunlight, direct sunlight, suppresses it. So if we're outside in the sun, as you know, we've done for time immemorial, that will suppress the pineal gland releasing melatonin. And then when it gets dark, melatonin comes up. And it's thought that this change, this rise in natural melatonin, is part of what induces a sleep cycle. Okay. So it would make sense if your day night cycle is off. And back in the 90s, I actually looked at a really, I was in the Navy and, you know, we travel around the world a lot, but there was a really decent study done where they used flight crews. If memory serves, it was actually Qantas Airlines where people flew from one side of the planet to another, 12-hour time shift. And they had different study arms. And the punchline was if you go to a different time zone and you take melatonin after you arrive at your new destination, an hour before you think it's bedtime, it significantly and meaningfully decreased your jet lag. You recoordinated to the new time zone. So that's great. What I find curious is can you think of any other hormone that you can get without a prescription?
Not well, you can do a drive-through testosterone clinic in certain states in America and get testosterone, but
But it's
that's
still
not
vaguely given to you
legal.
by a
Exactly. No, it would be what we call a doc in the box.
so melatonin is a hormone, but it has been characterized as a dietary supplement. And this is a real curious thing. This goes back to the Dietary Supplement Act in 1994, which says if something is in a human diet, if people eat it, it can be considered a dietary supplement as long as it's not expected to do excess harm. Really?
That's kind of vague, Dr. Yamamoto.
Well, yeah. So basically, what it means if people are eating something and we don't think it's going to kill you, then it can be labeled as a dietary supplement. So one must always be thoughtful when considering dietary supplements. What is a dietary supplement?
So
As
you're saying a dietary supplement is not FDA reviewed or approved?
right, somebody in the FDA deems
So
it
there
as
may not be
food.
quality standards that guide what is in that supplement,
There are some degrees of quality standards, and
but they're not FDA reviewed.
well, that's a
Correct.
moving target. So if you read what's there, there's basically it's important to note that a lot of people with good intentions are trying to give us things that we would get in our food. What I find always curious about melatonin is I guess I looked it up. Pigs have pineal glands, so I guess people were eating pig brains, so it passed through as a food that people eat. I have no idea. Nonetheless, it is true that dietary supplements have nowhere near the oversight, regulation, and rigorous review as regular pharmaceuticals. That doesn't mean you have to take a pill for everything.
Do you think melatonin causes heart failure based on this study, Dr. Yamamoto?
Absolutely not. So, one of the problems was in the UK, where most of the patients were, melatonin has to be prescribed. And so they compared people prescribed melatonin with people who weren't. Well, guess what? In this country, you don't need a prescription, you just go buy it. So they didn't really have any meaningful control. Also, uh, all it was really dredging the electronic medical record database. And they were looking for heart failure. Now, I got to tell you, Heart failure is not a medical diagnosis, really. At best, it's a description, and I can talk at another time about heart failure, how to prevent it and whatnot, but it is a billing code. And you know what? You can assign it to almost anything. There's a lot of criticism about what we call upcoding because reimbursement is based on your coding. So in this country and a lot of places, people get all sorts of clicked diagnosis of heart failure because it's medically feasible and it's a billing code. So you have a population of one versus another, and there's absolutely no mechanism. And heart failure is any condition where maybe you're breathless or have some congestion that you can tack onto a billing code. So the whole thing is really medical, scientific kind of garbage.
I'm going to go out on a limb here, Dr. Yamamoto, and say that this is an example of journalism creating clickbait because they know that we all are interested in our health, and many people in this country, in the United Kingdom, are taking melatonin. And if they highlight a paper presented at the American Heart Association meetings, gives it a sense of legitimacy, says, read this, it's about melatonin, American Heart Association, suddenly it's clickbait and patients want to read it. And the headline says melatonin either associated with or causing heart disease will get people to read that paper. And it is not good medicine. It's not the kind of medicine that real doctors, real medicine practice. And I am heartened by the fact that as soon as you search this on AI generated searches, if you type in faults in the melatonin study recently, AI will tell you all of the things that we just mentioned.
There are plenty.
So I am heartened by the fact that AI is able, even though I'm not very excited about its use in medicine, I am heartened by the fact that an AI generated search will reveal the problems with this study. It's an association study. It does not attribute cause. And this study was just released within the past couple of weeks. So to get already an AI generated critique of this study, pointing out the problems that we see with it, that it is not meant to be used for guiding clinical therapy. I should not be talking to you as a patient about melatonin and its use on the basis of this study. So I feel glad about that we can see that there's already very quick criticism, but I'm still very concerned about how much journalism, clickbait about medicine and medical research gets published, and it's dangerous. So let's all keep that in mind the next time that we hear something or read something in the paper. If it's a study that's highlighted by a journalist and it has not been reviewed by your doctor and it hasn't been what we call peer reviewed, take it with a grain of salt. These studies are not reliable for clinical decision making, which means not reliable for you to use in deciding about what you are going to do with your healthcare. This is an excellent example of what physicians, doctors are trying to protect you from. So take it with a grain of salt and don't automatically assume that because it's in the health section of your local newspaper, that is a recommendation that you should follow.
So there have been other things in the news quite recently. I heard that the powers that be are taking the black box warning off of hormone replacement. What on earth does that mean? And what does that mean to our real patients?
So what this means is that there are black box warnings for estrogen, usually uses estrogen replacement therapy for the creams that you would use vaginally, for supplements that you use as a suppository vaginally, for patches, and for pills. These are all the hormones of estrogen that we use in the perimenopause. And the black box warning was applying to the topical versions, things that we use to prevent urinary tract infections and to retain continence so that you don't have to have a leaky bladder when you're in your 80s and 90s. Those package warnings said that you could have a stroke, you could have cancer from using a topical estrogen cream or suppository, and it's simply not true and not supported by the data.
If you don't want to have a leaky bladder,
exactly,
80,
I don't.
which is like 10,000 years from now. But
Thank
you
you.
need to do something about it when you're younger. You
Correct.
have to be kind to your future self.
Exactly.
Your
Because that
future self
tissue
is calling
will
back
age.
and say,
Exactly.
please, please do something.
Exactly.
So you don't have to wait to have a problem to prevent it. And so,
Right.
as from my understanding, there are two main concerns about hormone therapy. One is cancer, which I'll leave to you, but really quickly, the other was quote heart disease. And I have to say, cardiologists used to think we were clever, telling everybody what to do about estrogen, but we got out of that business a long time ago. It's good to know that estrogen does improve blood flow. And so we said, yay, everybody take estrogen. But you know what? We didn't understand what a heart attack was, believe it or not, until about 1984. We used to think heart attacks were from spasming arteries, and estrogen helps to prevent that. That's one of the reasons why perimenopausal women get hot flashes, is because their arteries open and close so much. And if you think a heart attack is a spasm of an artery, it makes sense to give people estrogen. So in the 90s, we tried that. And we gave women having heart attacks estrogen. And you know what? It was a really, really bad idea because estrogen promotes clotting. And so, in the context of a heart attack, the last thing you want to do is give anyone a slug of estrogen because we
Dr. Yamamoto, what does a blood clot have to do with a heart attack?
right we it's this is important. We die when we clot. The heart has to pump blood to every last part of the body, except for the lens of the eye. But we pump blood everywhere. We, your heart and I. No. So if you clot off the artery delivering blood to the heart itself, well, that's a heart attack and it can kill you.
So a heart attack is a blood clot?
Heart attack is a blood clot.
Wow.
Stroke is a blood clot up to the head. Vascular dementia is often related to lots of little bitty blood clots. And we have a whole series on prevention of strokes and prevention of vascular dementia. But back on the estrogen topic,
So if I put estrogen cream in my vagina, am I going to get a blood clot in my heart?
no.
Oh, okay. I
Now,
might do it then.
that being said, your future self is thanking you already. But the no, it is true that one must be thoughtful about hormones and clotting risk. That is absolutely true. But you know what? We have a lot of ways of decreasing, mitigating, or eliminating clotting risk, sometimes with things as simple as aspirin. There are many, many conditions that can happen as we get older that promote clotting because that's basically how we die. So along the way, we can prevent clotting. But topical estrogen in particular, vaginal estrogen, every day I have a little joke with myself that says, I'm a cardiologist. Why on earth am I talking about vaginal estrogen? Well, you know what? My older patients, the women, are more likely to get hospitalized from having a urinary infection than they are from having a heart attack because we know how to prevent heart attacks. But if you haven't had adequate vaginal health, believe it or not, uh, that can really lead to these
Urinary tract infection and urosepsis.
which can be a bad thing.
Exactly. And they're calling it now the genitourinary syndrome of menopause. And that was what the press release was about this week from FDA and one of our local physicians. And so that hot topic in medicine is hopeful. And I think we have a good way forward. There was one more hot topic in medicine this week that I wanted to ask you about, Dr. Yamamoto, since
Okay.
you are the cardiologist. Um, it was drinking coffee in people who have atrial fibrillation could decrease the frequency of atrial fibrillation. How could that be?
So, atrial fibrillation, we love to call it a disease, and we have a whole show coming up just talking about atrial fibrillation. But what it really is a description. If you have a sustained irregular heartbeat, if you're older, we call it AFib. There are other ways your heart can beat irregularly, but it's extraordinarily common. And so to understand AFib means to it makes it clear why caffeine's not a problem. If you're a young person and you drink a lot of caffeine, it can rev you up, it can encourage some skipping heartbeats. People feel their heart race because caffeine speeds us up. But you know what? Caffeine has never been shown to be toxic, and we actually use it as a medication. It's a great headache medication.
But Dr. Yamamoto, I would think that if I drank coffee and I had caffeine, because it's a stimulant, that would stimulate my atrial fibrillation, wouldn't it?
Well, no. And see, this is a hugely common misunderstanding. Young people with skipping heartbeats, drinking a lot of caffeine, getting revved up, that's not atrial fibrillation.
It's not?
No,
What are they having?
they're just having these extra beats, we call them,
Sinus
premature
tachycardia?
or and sinus tachycardia. Your heart can race.
Is that harmless?
That is fundamentally harmless as long as you have a healthy heart. Young people typically have healthy hearts, but as you might imagine, if you are older and no one ever told you to treat your pressure and you beat up your heart for decades, or no one ever told you to take a statin so your arteries are all blocked and you got a blood clot and had a heart attack, if you have a damaged heart, racing it in an uncontrolled way can be a problem. But we can keep a heart healthy. What happens as we get older is our hearts always naturally slow down. And we know this, right? If you ever been to a gym, you can look at those big charts on the walls that say what is your expected maximum heart rate with age, and it's this downward slope. As we get older, it's harder and harder for our heart to speed up. That's a natural aging phenomenon.
So that might have something to do with an explanation for this study, Dr. Yamamoto.
Exactly. So
Because even the people who did this study could not explain a reduction of atrial fibrillation by 39% in people who had a cup of caffeinated coffee a day. How do you explain a reduction of atrial fibrillation when all of us think caffeine is a stimulant? What you might have an explanation.
sure,
They don't.
we actually here's what happens. If your heart's getting slower and slower naturally because you're getting older, and what I mean is 70, 80, it's rare to have atrial fibrillation under the age of 50. But when you're 70, your heart can be a lot slower, particularly if you're athletic and you started adult life with a slower heart. If you get slow enough, like I love to remind folks, if your heart rate is zero beats, you're dead. If your heart rate is only 20 beats a minute, you're almost dead. If your heart rate's 40 beats a minute, you might be an Olympic athlete or you might be in trouble or somewhere in between. If we're too slow, we do not circulate enough blood, and the body will give out the signal, please give me more blood. And so, Mother Nature's natural safety mechanism is to have the heart burst forth in an irregular fashion. And that's what atrial fibrillation is. We actually have a nice data set that your inability to raise your heart rate is a terrific identifier of people who are starting to have atrial fibrillation. So, you and I had a patient once who admitted to drinking, 14 cups of coffee before 10 o'clock in the morning?
Right, right.
And that was to keep his heart rate up to 40. And when his heart rate got slower, he hoped he had atrial fibrillation or he wasn't having a heartbeat at all. So the stimulant nature of caffeine can speed up our natural heart rate a little bit, and that will discourage atrial fibrillation.
So if I drink the coffee and I get the caffeine, and that speeds up what we call the sinus node, which is the body's natural pacemaker, then the atrial fibrillation kind of can't compete with that faster natural heart rate. And therefore, I'm probably preventing the atrial fibrillation because my sinus node is winning.
I would say,
and it's winning because it got helped by the caffeine.
Exactly.
Okay.
Atrial fibrillation.
I'm going to keep drinking coffee
in
then.
our future. Caffeine is related to an older asthma medicine. It actually has some circulatory benefits. Once I saw a paper relating it to lower risks of prostate cancer. That one I can't explain and won't try. But I never discourage my patients from drinking their coffee. And if you're a regular coffee drinker, for heaven's sake, don't stop abruptly or you'll have an incredible caffeine withdrawal headache.
So what you're saying is that we have an explanation that the authors of the study did not have for why caffeine, 1 cup a day, might reduce what we call our atrial fibrillation burden.
Right.
Certainly doesn't make it worse, which is what the authors of this study anticipated. So you don't have to avoid coffee. It might actually decrease your atrial fibrillation frequency. And the reason that you and I, Dr. Yamamoto, suspect that to be the case is because it's beneficial to the sinus node, which is your body's own pacemaker, which naturally slows down as you age. But if you give it a little stimulation via caffeine, you're actually assisting your sinus node in maintaining its normal sinus rhythm and now not allowing the atrial fibrillation to be the invader. I think
Exactly.
that's a good summary.
Now that doesn't mean go out and have, 15 quadruple espressos,
Everything in moderation.
including moderation, but exactly. So, uh, the morals of this story is caffeine isn't toxic. Melatonin's not going to make your heart explode. What else?
Uh, Appropriately applied vaginal estrogen can prevent urinary tract infections and maintain continence in the aging woman.
Without increasing your risk of heart attacks. Also on our vaccines.
Vaccines, now is the time. If you didn't get your flu shot, get it now. Have that discussion with your doctor about whether or not you want a COVID booster. And unfortunately, we have a variant of influenza H3N2 that mutated just around the time the flu shot was being created. But guess what? That's Mother Nature. We do the best we can, and the flu shot is still highly, highly protective. So get your flu shot. And thank you for joining us, Real Doctors.
Real medicine. And
We'll
stay.
have more updates for you in the next couple of weeks because I'm quite sure there's more clickbait out there. Thank you.
Thank you.